up fairly quickly. First thing I have is a request for bill introductions. Do I have any requests for bills? Seeing none, move on. First up, we have overview of performance measures with Brad Ridley with KDADS, Kansas Department of Aging Services. Okay.
Thank you, Mr. Chair, Committee. Again, my name is Brad Ridley, Director of Operations at KDADS. Here today, give an overview of our performance measures that are part of our performance-based budgeting submission that we gave you all. A couple things just to get started to note as I start walking through these measures, and I'll try to go through them fairly quickly. I think we have 28 slides and there's a lot of information, but I'll try to hit the highlights of what I think has been more of a hot topic for this committee and try to key on some of those areas. First, regarding these metrics, and these are measures that are not necessarily new this year. These are things that we've been measuring as key metrics for the agency for some time, many years. And these are just what we consider key metrics as well that we put as part of this budget. Historically, they've been embedded in our budget narrative, just now in a different format that's been presented to you all this cycle. A lot of our performance measures, just because of the services we provide at KDADS, are focused on number of people we serve in our different service areas. And in some cases, we do have some key metrics that are focused on quality.
Committee, you'll find KDADS on 452 to 460 in your books for those of you that have books, 452 to 460. Okay, Brad, sorry to interrupt.
No problem.
Thank you.
So as I get started, we've kind of grouped our programs into 4 primary program areas of the agency: our aging services programs, our Medicaid programs that are part of KDADS, and our behavioral health services, as well as our survey, certification, and credentialing program. So first I'll start on slide 2 with our aging services program. The first slide here just gives an overview of the funding, our actuals, and our budget for FY22 and FY23 for this program. I will note that got the state general fund, the non-state general fund, and what the non-state general fund is our considered fee funds or special revenue funds that are state funds but not out of SGF, and then of course our federal dollars. Moving to slide 3, our primary group of services in our aging services program is the Older Americans Act program. This is a program that's primarily federally funded through grants through the Administration for Community Living. And on slide 3 gives you an idea of how many people those Older Americans Act services serve. And you'll notice as a theme through our performance measures that we have noticed a dip in FY20 and through calendar year 20 related to COVID, how COVID has provided an impact to many of the agency services. So on slide 3, you'll see that the number of people receiving services through the Older Americans Act did get reduced substantially in 2020. But as we monitor these key metrics, they'll be even more important as we monitor for that bounce back that the agency expects to see as we come out of the pandemic. Moving on to slide 4, these are more quality assurance metrics related again to the Older Americans Act services. We have a quality oversight process that reviews files and interviews customers to see how well those services are being provided to the individual themselves. And this gives you a snapshot of a few metrics around that quality assurance for the Older Americans Act. Moving on to slide 5, big portion of the Older Americans Act services is the nutrition program. These are the meals that are provided at senior centers and through home delivered meals. Slide 5 gives an overview of how many meals are provided in each year. Again, noticing the 2020 dip that is related to COVID and a reduction in home-delivered meals, as well as congregate meals staying fairly flat because there were some initiatives during the pandemic to ensure that while there might not have been a congregate setting, that those meals were provided in a grab-and-go and different innovative methods to get those meals out to individuals. Moving on to slide 6 is a group of services that is familiar to this committee, known as the Senior Care Act. These are basically state-funded services that provide in-home support to individuals who are not at another payer source such as Medicaid at this point. So these are the number of people on slide 6 that are served under the Senior Care Act. Moving on to slide 7, these are performance quality metrics around the Senior Care Act, monitoring that quality assurance of those services. Slide 8 is an overview of the Aging and Disability Resource Center. The ADRC is basically a one-stop shop for information individuals need to look at different long-term care services. So the two graphs there are the number of assessments. These are functional assessments that the ADRC provides to individuals seeking home and community-based services under Medicaid. And then there's also a call center for the ADRC, so monitoring the number of phone calls that come in and individuals are supported via the call center. Slide 9 gives an overview of our care assessment process. This is the client assessment, referral, and evaluation assessment. These are assessments that are required of anyone entering a nursing facility. There's a federal requirement to have those assessments completed. So you will see, again, the theme of there was a dip during COVID for 2020 when some of these are all face-to-face assessments. So when a lot of those assessment requirements were relaxed or delayed during that process. But again, these are services we anticipate bouncing back to normal levels once we get out of the pandemic. On slide 10, this gives an overview of our quality assurance process on how many individuals in these programs that we target to contact and review and survey to make sure that the services they are receiving are of good quality. The next two slides, slide 11 and slide 12, give an overview of two federal grant programs that support Medicare individuals at the local level, here at the state level. One is the Senior Health Insurance Counseling Service, also known as SHIC. On slide 12 is the Medicare Improvement for Patients and Provider Act. So these are grants we get from the feds that provide support to individuals seeking assistance with Medicare. So that's an overview of the aging services program metrics, and I'll pause there if there's any questions.
Thank you. Thank you. Committee questions? I have just one quick one. Back to slide 6, 3,800, I think it is. Yeah, 3,801. So what do you think the potential is to serve that, and what would be the barrier that they wouldn't be served?
I think that's something we're still working with the main service organizations for the senior care are area agencies on aging, and we are working with them. Again, Senior Care Act is a program where you all appropriate an additional $3 million this year. So we're evaluating with them how we're going to incorporate that, how they plan to incorporate that at their local level on getting that program back up to 3,800. So I think rather than just serving more people, I think this is another program that is encountering workforce issues. A lot of that additional funding may be put into the rates that have to be paid for those services. The agency is also working with the AAAs to adjust the client obligation. So similar to Medicaid, where there's a patient liability, there's a client obligation for Senior Care Act as well. So the agency is seeing if there can be some adjustments made on that will more align the Senior Care Act client share with what Medicaid is aligned with.
But I thought we did away with the client obligation last year.
For Medicaid, but Senior
Yes,
Care Act still has
I got you.
a patient share as well.
Well, the only reason I ask is because every one of these folks we can potentially serve, we can keep out of an assisted living or
Correct.
a nursing home or anything like that.
Correct.
And this would be a wise use of our money versus what we pay out.
Yep.
in Medicare and nursing homes. So,
Yep.
Okay.
And the Senior Care Act is usually the target population there are the individuals that have not yet spent down to become at that Medicaid level for financial qualification.
Exactly. Committee, further questions? Okay, very good. Continue on. Thank you.
So the next agency's program that I'll walk through is our Survey Certification and Credentialing Program. This program has a couple main areas. This is the program that does surveys and inspections of our nursing facilities and other adult care homes, as well as some IDD and mental health facilities. So slide 13 gives an overview of the funding for what we call an acronym SCC program. On slide 14 is an example of a couple metrics around the survey process. The first one being the average number of months between surveys. So what our average is, number of months between doing a survey at each facility. And the second graph there has the number of adult care home surveys completed, which when we talk about adult care homes, these are the state license only facilities like assisted living facilities. Slide 15, part of the SCC program is a background check program where we run background checks on different registries. And this is one where I would note that we do expect an increase in 22 and 23 for those background checks that will be submitted through the agency. And that's the last slide on that program, and I'll pause for questions.
Committee questions? Representative Howerton.
If you can go back one slide.
Sure.
On 14, I think it is. Maybe the metric one, yes. How many facilities? Is there a percentage? Like how many do you actually get surveyed?
So for nursing facilities, we have, I think, around 330 nursing facilities in the state that would be part of that average.
Survey, you're going in to inspect them?
Correct.
Okay, so you get to them about once a year then?
The target is once a year, yes. And so based on where we're at today, we're anticipating in 21 and 22 being at about 16 months between surveys.
Committee, further questions? And Brad, how many different kinds of facilities do we have?
So the basic categories are nursing facilities, and then our state licensed adult care homes are our assisted living facilities. There's a couple different levels of those. This group also oversees the survey and licensing of our IDD facilities, so our residential facilities that are part of the Hcbs IDD program, and then mental health survey as well for mental health facilities.
And then we do have some private facilities too.
Correct.
Just a few. Okay, committee, further questions? Okay, continue on.
Moving on to slide 16, this is the KDAD's portion of the Medicaid program. So when you think Medicaid program, where KDHE is the Medicaid agency, there are programs that are operated by KDADs under the larger Medicaid and CanCare program. So slide 17 gives overview of the funding for our Medicaid program. And the primary services you'll hear about with the Medicaid program are home and community-based services, our Hcbs programs, our nursing facility program, our PRTFs, I'll walk through some metrics with our PRTFs, are kind of the core Medicaid programs that are most commonly heard about. On slide 18, this gives an overview of the 7 Hcbs waivers that are part of the overall Medicaid program. You'll see the numbers, they're kind of grouped. So the first 3 waiver programs there, if you look at the numbers are pretty flat. Those are 3 of our programs that have a wait list. So those number of slots are basically capped by appropriation. Our SED program is pretty stagnant around that caseload. And then the last 3 are frail elderly, technology assistance, and brain injury programs are 3 programs that we are seeing a rise in number of persons served on those programs. And you can kind of see in our estimates where we expect that trend to continue. Slide 19 is more of a visual version of the prior chart, just gives a graphic visual of the same numbers. Moving on to slide 20, these are the numbers of those 3 programs that do have a wait list and the tracking of those wait list numbers over time and what the agency projects moving forward. Slide 21 gives a metric around the nursing facility program that's in Medicaid. The thing to note on this slide is the decrease that's been impacted by COVID from 2020 to 2021. So we're closely monitoring that caseload each month to see how that caseload is either stabilizing or potentially increasing. And on slide 22 is some caseload around our PACE program, and PACE is the program for all-inclusive care for the elderly. One way to describe PACE is basically another managed care program outside of CanCare for seniors that is, it's not fully statewide, but covers a good portion of eastern Kansas, depending on catchment area there. So again, PACE is another program that we have seen rise over the last few years, and we anticipate continuing to rise in number of persons served through that program. Slide 23 are some numbers around our PRTFs, which are psychiatric residential treatment facilities for children. Those 2 slides show our current caseload of monthly average of individuals served through Medicaid. The second graph are number of kids that we see on the PRTF wait list. And they are the examples of the metrics I have for our Medicaid program. And so I'll pause there before I move on.
Committee questions? Representative Ballard.
Thank you. Okay, if we're looking at, let me see, you said the monthly average is that we have like 270, right?
Are you talking about the PRTFs?
Well, I'm sorry, 280. Yes.
Yeah. Yes.
Slide 23.
Yes.
All right. So we have. We'll just look at 221, 297. So we had a decrease going into 222. But we have a waiting list of 145, well, no, waiting list of 147 right now?
Yeah, so just to clarify too, the FY22 numbers and the FY23 numbers are projections, and the darker blue there are the actuals. So we are anticipating a slight decrease in FY22, and that's primarily around when these estimates were put together this summer. That was basically around the concerns of staffing, and there might be licensed beds, but I know there's a lot of PRTFs struggling with staffing to keep those beds staffed. So I think we've seen that may impact our ability to maybe have a slight decrease in our PRTF caseload.
Mr. President, one more. I'm just trying to think. What was our max capacity? You heard this.
Well, I was going to elaborate on that. We have an entire building that's empty that we could take care of this wait list without if we had the staff, is that?
I think that's the main issue here is most recently has been staffing at
We
the
have the
fair, yes.
beds
Right.
to eliminate the wait list. We did that last year, but we can't get staff to open the
It's how many of
building.
those beds are staffed, yes, that's correct.
So,
But if I might, one of the reasons why they can't open the building is that they can't find the people to work it.
right.
Okay, so, I mean, that's why
What was it, 100?
106, yeah, I think it was 178, something like that. And that's why I was looking at these figures, because it wasn't conniving, but then I remembered, we do have the space, but it's finding people to staff it right now is where the problem really is.
Correct.
Thank you.
Committee, further questions? Okay, very good.
All right, the last program I'll talk about here is our behavioral health program. Kind of three main service areas under the behavioral health program: mental health services, substance use disorder services, and problem gambling. Slide 24 gives an overview of the funding related to behavioral health. Moving to slide 25, this gives some breakdown of caseload for our SUD services as well as our mental health and problem gambling and treatment. On slide 26 is more of a graphical representation of the same numbers for substance use disorder. Slide 27 is more visual for the mental health treatment services. And on slide 28, these are numbers around our crisis centers, which has been a hot legislative topic the last several years. These are the services that are funded through both state general fund and the lotto vending machine revenue that we've had the last couple of years. And that kind of gives an overview of our behavioral health. So with that, that's all I have for presentation. But happy to stand for any more questions.
Very good. Committee questions. Representative Ballard.
All right, slide 25 for the problem gaming. I'm trying to remember, and see, we get over, what do we get, over 2 million?
No, that's quite a bit more than that.
Well, I'm trying to think.
Oh, you're talking about problem gaming.
Yeah, problem gaming.
Yeah.
I'm sorry. But the reason why I'm saying that is because our problem gaming funding, because I think it's 2% that we get of whatever the funds are, I can't remember now, but we have quite a bit of money in there, and that's the fund that people have used to get for other funds because we haven't used it all. But part of problem gaming, just for the new people, so you know, it was supposed to be for advertising, making sure there was programming in all the communities, especially the ones where they have the casinos, since the state owns some of those. And I was just looking at, so when I see problem gaming here, it's number of treatments. 2017, 189, 21, 223. So even though we are increasing that number, I'm just looking at it. So is the actual 2021 is the one at 223 and the rest is projected?
So the 21 number from problem gambling is projected. The 20 and before that numbers are actuals. So we do anticipate that to slowly increase. And so as we look at that problem gambling budget, which I know we'll probably talk about later this session in this committee, we try to make sure we have enough funds for at least that treatment, as we know that's growing. So we kind of evaluate that each year within that problem gambling budget.
Thank you, Mr. Chairman.
Any further questions? More of a statement than just for the new folks, and also just the committee knows that we were one of our top priorities last year that we accomplished was a PACE, and we've been on PRTF for a number of years, and unfortunately that building's not occupied, but we could do away with those wait lists, but it's been one of our top priorities out of this committee for the last couple of years, and that wait list would be gone if we could find the staff for that building. Representative Clifford.
Mr. Chairman, thank you. Where's the facility located? Because, taking kids from Western Kansas to Kansas City isn't great.
This is in Kansas City. I think Isn't it in Kansas City, the empty facility?
I'm actually not sure. I'd have to follow up on the details on that.
I had some conversation with Andy Brown.
Okay.
I think it's in Kansas City. I think it's in that area at least. Anyway,
Follow up, did we not get beds open in Hayes, Kansas, or reopen this year?
Yeah, so the legislature funded, I think it was last year, funding for, and there's two types of beds when we talk about Hayes. There's the hospital beds, psychiatric hospital beds, and then the PRTF. PRTF is a lower level of care. So right now we do have PRTF beds in Hayes, but several years ago we lost the hospital beds in Hayes. And so we did have a procurement open to get more hospital beds back in Hayes, and we did sign a contract to get those beds built. So there is a plan moving forward with an organization to get some beds back in Hayes for the hospital side.
and I think it's next spring is when it's projected to be finished.
Yep.
And just follow, I mean, you probably know this, but just for perspective, from where I live, it's 2 hours to Hayes. From Elkhart, it's 4. So tough on parents, especially if they have to come east.
Yep, for sure.
Any further questions? Brad, thank you.
Yep, thank you all.
for being here. I just might want to tell the committee that Representative Lynn is on WebEx, so. Who had a question? Oh, I'm sorry. I don't have a raised hand on mine. Okay. Yeah, I'm not on WebEx, but Representative Lynn, sorry about that.
That's okay. Thank you, Mr. Chair. I was just wondering if we have any metrics on successful outcomes of these programs, or if they're keeping them.
So we do have some metrics around quality assurance. There's a few that we had highlighted in the key metrics, but we do have several quality oversight programs around Hcbs and several of our programs that we monitor the success of those programs. So we highlighted some of those in the key metrics, but we do have many more within the agency that are not identified in this process.
Okay, thank you, Mr. Chair.
Very good. Brad, thank you very much for being here. I know you'll be seeing a lot of us here in the next couple of weeks or month probably. Okay. Just wave at me or something when Representative Lynn has a question, okay? Okay, next we have Ryan Lester, Adhe, Director of Health Promotion. And
hey, good afternoon.
WebEx.
Yes, sir. Can you all hear me? Oh. Can you hear me?
Yes.
Oh, fantastic. Thank you so much. Well, good afternoon, Chairperson Carpenter and the Social Services Budget Committee. I'm Ryan Lester. I'm the Director of the Bureau of Health Promotion at KDHE. I really appreciate the opportunity to highlight some of the accomplishments of the Division of Public Health there at KDHE. For context, I thought I would give you kind of a 10,000-foot overview of what each of the bureaus within the Division of Public Health do, and then drill into a little bit more detail about the accomplishments that each of these bureaus are really proud of. And to note, each of these bureaus track so many things that don't necessarily show up on that balance sheet. So there are so many things that are done that aren't trackable with outcomes and measures and outputs and all of those sorts of things. So I'll start with the Bureau of Community Health Systems. The Bureau of Community Health Systems provides programmatic alignment for improved coordination of programs and services which continue to grow. The Bureau is made up of a diverse set of programs that enhance the health and safety of Kansas communities by strengthening public health systems through collaboration, support, and monitoring. The Bureau of Community Health Systems partner with state and local public health communities to coordinate programs through local health departments, hospitals, clinics, associations, universities, and others. The Bureau administers aid to local grants and supports quality primary care retention throughout the state. The Bureau also promotes best practices within the health of the community at a community level and then also at an individual level to impact Kansans as individuals. Another function that the Bureau provides is the development and enforcement of a variety of regulations. So the one measure that I really want to point out that the Beaches is super proud of is an access to primary care measure, and it is the number of unduplicated patients served by state-funded primary care clinics. As you can see in fiscal year 2021, that number is 289,037. That's a lot of lives impacted positively. And this metric is really important for the Bureau in the Division of Public Health because it represents the growing number of patients receiving primary care from Kansas safety net clinics. State general funds through the community-based primary care clinics program provided by Beaches enable safety net clinics to serve Kansans who generally have no other option for healthcare. By providing that timely care to address patient needs, those needs don't further deteriorate into worse health conditions, which are often more expensive and more invasive to treat. The funding to primary care clinics creates and sustains an ever-growing infrastructure and promotes partnerships with other programs within Beaches, but also across the KDHE as an agency. So the next bureau I'd like to highlight is the Bureau of Disease Control and Prevention. The Bureau of Disease Control and Prevention is the operating unit principally responsible for programs designed to prevent and control communicable diseases of crucial public health concern. The Bureau tracks and ensures effective treatment and reduction in contacts for infectious disease cases, mainly around STIs, HIV, and tuberculosis. The Bureau also promotes and tracks immunizations in school-age children. The Bureau was charged and is responsible for the development of the statewide Kansas Immunization Information System, known as WebIZ. And WebIZ consolidates and maintains immunization records for all Kansas citizens, and also it supports healthcare providers who administer those vaccines. One of the measures that I really want to highlight from the Bureau is that the number of contacts per infectious tuberculosis case identified has reduced from 17 in fiscal year 2019 to 12 in fiscal year 2021. And why this is really important is this outcome really shows, or is really the result of fewer large outbreaks associated with infectious TB cases, which is a good thing for our state. The next bureau I'd like to highlight is the Bureau of Epidemiology and Public Health Informatics. The Bureau of Epidemiology and Public Health Informatics, we affectionately refer to as BEPI, consists of three core functions of public health activities that comprise one, infectious disease and disease condition identification and management, two, vital records registration, issuance, and statistical analysis, and three, the health assessment and information dissemination. BEPI is responsible for collecting and analyzing and interpreting data that provide information on a variety of conditions of public health importance and on the health status of the population. We really think of BEPI as like that because of the data that they provide. They're kind of like the lifeblood of our agency. In addition to that, the Bureau conducts, in partnership with local public health departments and other state and federal agencies, timely investigations of and surveillance related to infectious and zoonotic diseases, environmental health, maternal health, and child health, trauma, and other public health hazards. So in 2021, the measure that BEPI is super proud of is that they sent 92,882 cases of reportable diseases to CDC. They produced 402,632 vital records and fulfilled 566 data set data requests, education trainings and presentations, or articles and summaries published. As you can see, BP has had a very busy year this year. But again, the data is the lifeblood of what we do. So we expect BP to be busy at all times. The next bureau that I'd like to highlight is the Bureau of Family Health. The Bureau of Family Health are authorized or mandated by state and federal laws to administer a variety of statewide programming. The programs and projects administered through the Bureau meet the needs of infants, children, adolescents, women, pregnant women, men, individuals with special healthcare needs, and families birth to age 44. Programs are targeted towards the highest risk populations, accessing and receiving care and services throughout the lifespan. Programming really integrates the social determinants of health and health equity in an effort to address and eliminate ethnic, racial, and socioeconomic health disparities. You'll see that as a trend across the agency as well. The program or performance measure I'd like to point out for family health is really around the administration of the Women, Infants, and Children's Program, also known as WIC. WIC is a service that the Bureau of Family Health, like I said, is super proud of. In fiscal year 2021, 76,424 pregnant and postpartum women, breastfeeding mothers, infants, and children up to age 5 were served by the WIC program. And so the overall mission of the WIC program is really to safeguard the health of low-income women, infants, and children up to age 5 who are at nutrition risk by providing nutritious foods to supplement diets. They provide information on healthy eating and referrals to healthcare when necessary. So as you can see, that 76,424 lives have really been positively impacted by the WIC program. The next bureau, and one that I'm particularly fond of.
Brad, excuse me for a minute.
Yes, sir.
I'm not sure how much time you have left, but again, we do have to be on the floor. It's kind of an unusual circumstance at 4:30, and we have two other people, Mark and Dan. So maybe we can have you back another day if you've got a lot more, or if you could kind of wrap it up here. I was kind of looking maybe in a few minutes if you could kind of wrap it up. And
Sure.
give those guys.
I maybe have.
I apologize.
I have 2 minutes.
Okay, you got it.
Cool. Excellent. Thank you. So the next bureau is the Bureau of Health Promotion. And really what we do is chronic disease, injury and violence prevention and control from a very upstream standpoint. So we're looking at policy systems and environmental changes that really positively affect the lives of Kansans. So in fiscal year 2021, the Bureau of Health Promotion supported 134 community or state level coalitions. Those coalitions address things like nutrition, physical activity, tobacco use and vaping use prevention, injury prevention, substance use disorder prevention, cancer, diabetes, heart disease, and stroke. And why that's really important is, the community coalitions are really like the boots on the ground. They're coming together to solve community level problems. And then the last bureau I want to talk about is the Bureau of Oral Health. And really they strive to increase awareness of oral health through education, surveillance, and outreach throughout the state. It also really focuses on those at-risk populations like children and the elderly. And the one measure I want to really point out here is in fiscal year 2021, the Bureau of Oral Health served 65,655 children through a screening program for dental disease. So that's super, super important. And I appreciate your time and attention to all these measures.
Very good. Thank you very much. Committee questions.
I won't ask you a question, but I'm interested in that last figure you had for oral health. It was
Yes,
like,
ma'am.
I think you said 65,000 children.
Mm-hmm.
Is there a breakdown on that and where it was and everything? Could you give us that information, please?
I don't have that with me today, but I can certainly get back with you on that.
Oh, that'll be fine. Now, did you do anything with seniors at all, or was it just with children?
Let me double check right quick on the performance measure document here. I believe it was mostly targeted for seniors, but they are for school children. Yeah,
I won't take up any additional time, but with whatever you have, if you could send, because oral health is really a big area, especially for seniors, but it's really important for children too. So thank you so much. Thank you, Mr. Chairman.
Representative Clifford.
Thank you, Mr. Chairman. On the tuberculosis, are folks coming into the state with screened, so we know they aren't coming into the state with it? Are those 12 just household contacts, or do we presume there's still community spread even at a very low level? Thank you.
that is a really great question, and I'll take that back to the Bureau Director of Disease Containment and get back with you.
Very good. One thing I'll say just is these guys track everything. I mean, there is nothing you can think of that they don't have the stats on, and I mean that. So they do a great job. So very good. Thank you for being here, Ryan. And sorry we're in such a hurry today.
Thank you.
Okay. Mark Heim.
Yes, thank you, Mr. Chairman.
Very good. I'll tell you a quick story on Mark real quick. And when he took that job over, I'm always looking for information on things, and he changed jobs. And so he was new in his position as a Medicaid CFO. So I called him one day and I said, yeah, I need some figures on the capitation rate and the per member per month. And he said, yeah, I'll get right back with you. And I knew he couldn't provide them for me, but anyway, I tried. And he called me back in a little bit and he said, Representative Carpenter, I can't give you that information. I said, I already knew that, Mark, but I tried. You remember that?
Well, they barely give it to me, so.
So anyway,
Yes,
thank you for
that was
being here.
Hey, that's all right. I thank you for telling that story on me. I appreciate that. So thank you, Mr. Chairman and members of the committee, and I think I can be fairly quick. I understand you're pressed for time, so and just so you know, I'm working from the document, and I'm guessing that you all have it in front of you. This is the document put together by Legislative Research that, you know, it was roughly, I think, 600 and some pages, but the healthcare finance section of KDHE starts on page 443, and it starts with the Medicaid program. And so we, you know, the way the template in that book is set up, we start off a little bit explaining the consequences of not funding, and then, you know, it asks, are these a mandatory program? Medicaid is, yes, and it is a required match program. And we do have quite a bit of history there, which I certainly won't read to you now, but, you know, would like to offer that if there's anything else you would like or any questions you have once you have a chance to read through that, please let us know and be happy to follow up on that. So we did provide quite a bit there in terms of some legislation that's happened over the years and other things. But moving into the measures, our measures center on what is known as HEDIS, and that's HEDIS, and it's the Healthcare Effectiveness and Data Information Set. And those are governed or kept by what's called the National Committee for Quality Assurance, so NCQA. One thing about Medicaid and the Medicaid world, lots and lots of acronyms. Hard to keep track of them all, but NCQA, the Quality Assurance Committee, they do this for all insurance providers, these HEDIS measures, whether they be Medicare, Medicaid, private insurers. They have a tie to CMS. So widely used throughout any kind of insurance type industry. And for the most part, these HEDIS measures are tied to specific age groups. And I'll talk about that a little bit here as I move forward. But for state Medicaid programs, kind of the target or the national standard is try to be stay in the upper 50th percentile. That gives a target and like I said, where you want to be as a state program. So moving in, and I'm at the bottom of page 444 if that helps, but the first one we speak to is the A1c Test, and this is testing for comprehensive diabetes care, and these would be it's diabetes screening, and this would be for beneficiaries who they've already been diagnosed with diabetes, and so this is a test for a blood sugar test to make sure they're in a safe range, acceptable range, and this is basically what I think of as a preventative type care measure. This one does have a very wide range in terms of the age grouping because it's 18 to 75. So a very wide range. Most of the HEDIS measures are not that extent. But anyway, I will move to the second one. And I want to spend a minute on this one because this is interesting to hear Representative Ballard's comments, because the second one, as you can see, it revolves around dental visits for that 2 to 21 age range. And, I think everybody would agree. Seems like you hear more and more about it all the time, that the dental health is now being recognized, it's so important to your overall health. And this actually used to be something we tracked for a P4P measure for the state's MCOs, the managed care organizations. The good news is that the MCOs do so well at this, at these dental visits, that has actually been taken out of the P4P. I don't want to get sidetracked on the P4P, but those are performance measures that we lay out for the MCOs to meet. And when they get to a point, if they're meeting a P4P so well, they're doing such a good job of it, which on the one hand is a good thing, but then we are allowed to switch those up at times because then we want them to move to focusing something else, not drop off on the, where they're doing well, but it gives us a chance to add some other things to incentivize them to target. So, but yeah, so the dental visits for that 2 to 21 age group, certainly a very important one. And then number 3 we have are the weight assessment or the BMI for children and adolescents. Again, this is pretty specific age range, 3 to 17, children and adolescents. The BMI, just for anybody that's not aware, that's your body mass index, actually is for the state insurance. We're actually measured for that as well. So that's a common measurement, kind of gives you your ratio, your height to weight, and a range of where you should be and where you are. But this can even involve counseling for nutrition, counseling about physical activity if that is needed. And I wanted to comment here because I think this shows the importance of this, but nowadays, or in current times, so to speak, it's actually pretty well thought that parents actually consider the childhood obesity to be more of a concern than even smoking, drug addiction. It tells you maybe somewhat where we are, in terms of society overall, that it is such a concern, and it certainly can have a tie to diabetes as well. So another one that's highly important to a wide range of people. And just a comment on these HEDIS measures. So beneficiaries oftentimes move in and out of Medicaid depending on their circumstances at any given time. To be counted in a HEDIS measure, you've been a Medicaid beneficiary for at least a continuous year. And I think that makes sense because they're trying to track progress over a time frame. And so if you're moving in and out, you're probably missing out on being counted on this. But just a note I wanted to add. Very quickly, the next program is our administration. So administration that administers the Medicaid program. So the Medicaid program is obviously a very large program. And the administration side, the data tracking, the caseload, as Representative Carpenter, Chairman Carpenter is very familiar with, those things are under the administrative side. And again, yes, statutory requirement and or a mandatory requirement and a match requirement as well to administer the Medicaid program. But the measure I'll point out there very quickly is the agency was put on a cap, and that's a corrective action plan by CMS several years ago. And this measure came out of that. The cap was to initiate some training program. And so that's exactly what this is. It offers Medicaid courses, Medicaid related courses, whether it be on eligibility, Medicaid history, how the state, where Medicaid was, how it's evolved over time, where we are now. And these are courses that are actually taught by employees, staff here in KDHE. Great courses. Actually, some of them are required for new employees, and then there's a number of extra ones who are offered. And this goes to providers and can even extend to providers and other stakeholders as well. So I see there's only 5 minutes left, and maybe I'll pause for a minute and see if there are any questions and try to save a little time, I guess.
Many questions. Yeah, we have to be out of here at 4:30. We have to be on the floor, so.
Okay.
And Dan's not going to have much time.
Representative Carpenter, I have nothing additional to add. Thank you all for the opportunity today for our agency to present on our performance measures. And if you have any other questions, we'll be happy to address them. Thank you.
Well, I appreciate that. I know we'll have questions later, and at some point in time, we'll be digging into the budgets here in the next few weeks. So thank you very much. And I apologize again. It was kind of a short notice that we're going to be on the floor at 4:30. So with that, thanks again for being here. Dan, you ready? All right. You've got about 7 minutes, so that ought to make it about right for you. Thank you for being here. He's a familiar face with the Department of Children and Families. We'll be seeing him a lot. And so, again, thank you for being here.
Thank you, Chairman.
And that starts on 365 to 426. And then also, if you have your computer, there is a program in here that Francie sent. Yeah, that's what I'm looking at right here. Okay.
I think you have our testimony. One that looks like this. This is testimony we provided just a few weeks ago to the Legislative Budget Committee on performance-based budget as they were looking at it. Much of what the other said, we have 9 major programs, and under those 9 programs, we have 59 sub-programs. With most of those, we have performance outcomes for those. Some of them are administrative programs, which don't. They just support the others. So in our testimony on page 3, we ranked all of our programs and sub-programs, and you can see that ranking there. The programs are ranked, and then each sub-program under there and the budget amount. I'll flip over then to page 5. That's where our performance measures start. We have 95 of those, and also in the KLRD packet, we filled out their form, and there would be a separate page for each of those. But what I did is, on our testimony starting back on page 9, I picked out a couple key performance measures. We graphed them out from 2016 through 2023 and kind of explained the ups and downs in each one of those. So on page 9, the first one is in our Prevention and Protection Services program, which is our child welfare, the Protection Report Center, and the percent of initial assessments completed timely. And in that graph, you can see in 16, we were up in the 91% range, and then it dropped from 17 to 18, and then we've continued to go back up back into the 90s. That was a time when we had a lot of staff turnover, some changes in the program. It took a year and a half to do training and get that stabilized again, and since then it's increased. On the next page, we have an outcome for foster care, percent of children in out-of-home placements less than 12 months who had fewer than 2 placements. That is a outcome we track, and also one that was part of the recent McIntyre lawsuit. In that one, while it dipped down into 18, it's increased, and we expect that to continue to increase. Mr. Chairman, in the testimony, I have several others that cover child support and all of our other programs. I know we are out of time. I can continue to go through those or take questions. And
Why don't you hit the child support one real quick?
okay. On page 11, we have 2 outcomes related to child support services. The one on the top of the page is the percent of current child support collected. The current child support's been increasing. You can see from 16, 17, 18, 19. 2020 was the largest percentage we've collected. That's primarily related to the economic stimulus payments, which made the collections easier. That's also the same in the bottom of page 11. Those are percent of cases paying support in arrears. We were kind of flat, 16 through 19, and then you'll see a big spike in 20. Again, that's related to the stimulus payments and debt set-off. We were able to collect a lot of that and route it to the children. So big spike in 20, again, with it's continue to stay kind of high in 21 as we captured those other payments, and we hope to continue that through 22 and 23 at that level.
Very good. Committee questions. How's your new vendor working?
Yeah, we have 2 vendors under that new contract, and I think they're working out good.
Very good. And I apologize again for having to hurry through this.
I understand.
For the conferees and everybody else, but we've got to get to the floor. Well, Dan, thank you very much, and you'll be hearing from us as we get into the budget here in the next couple of weeks.
Thank you, Chairman.
So, committee, I did hope to have a informational hearing on child support, but I think we're out of time for this year. We have next week's agenda already decided, and then the week after that, it's boots on the ground, go to work time. So, all right. Well, thank you, everybody, for being here, and thanks, everybody, for testifying.
Thank you all.
We're adjourned.